if we select in a range of 0.5 difference that what we have selected in the office, well, this is possible without increase of risk. We can play with 0.5 difference in width of the implant without any problem, no risk. If we play with 1 centimeter difference, we are borderline problems in many patients. But if we select lateral smart intermammary distance, the implant border may be palpated and seen. So the limit is 1 centimeter between what we decide in the office. Because if we select more than 1 centimeter, it's not recommendable, because in the majority of patients we will have problems, palpability of the implant, symastia on bad results. The implant height, sternal knob to nipple distance has been extensively used as a guide in deciding the implant height, and I still use it. If it's less than 17 centimeters, I use low implant. If it is between 70 and 22 centimeters, I use a medium height implant. And if it's over 22 centimeters, I use a high height implant. And the projection for final decision. Well, the footprint has no volume. We can have the same footprint with these different volumes from 170 to 375. So we have to select depending on the projection we want to have in the patient, and that is depending on the patient desires and is depending on the quality of the tissue, of course. Depending on the patient desires. However, do not forget the envelope. A loose envelope may need more projection or a mastopexy. If we select low projection in a loose envelope, the result will be very bad with a ptotic gland. So we have to stretch the lower pole skin and make a measurement, and we have to use the same principles in the perioperative markings to calculate how much skin the implant will fill. Also, there are clinical indications, and that is something that I have published, the clinical indications to select the projection. For example, in cases of aplasia, that is the same of breast reconstruction, there is no breast, I use a high projected implant. In cases of hypoplasia, I use medium projection. If there is no hypoplasia, I use a low projection, but I can use also a round, because the low projection implant is similar to a round in cases of no hypoplasia. In cases of medium doses, I use a high projection anatomical implant. If I have moderate doses, I also can perform a periareolar mastopexy with medium projection implant. And in cases of tuberous breast, depending on the degree of the tuberous breast, I use from medium to high projected. If it is more severe the tuberous breast, I use high projected implants. There are new weapons to take the final decision. We have to implicate the patients. I don't know if you are using that simulating system with brass and... Do you know them? Yes, you know? You know? They are very useful, especially to convert the surgery. If the patient has some doubts about the result, and see with the brass, that is the good part of the visit. Let's go to the shop and discuss to make different options in front of you. It works very well in my office. You know, we have 8 different options from 85 grams to 430 grams. And now we have the 3D imaging techniques can offer a fitting room for breast. You have a 3D dimension system, the vector system. Have you ever used it? I don't have in my office, but I've tried it, and it's incredible. It's incredible because, and I think in the future we will need to have special room for that system, not only for breast, just for the rest of the surgeries, for those for body contouring, we will need a room, special room for 3D pictures in 2 or 3 years. Because with one click, we have all information, even measurements, with one click. The system is able to make the measurements of the patient. I wanted to do a breast augmentation for many years, but I never dared to, because I have some certain about what the outcome will be. That is the typical patient for a 3D one-click visit. And that is a real case of the simulation with the MF335, and is a real case of the 3D image after the surgery. It's a real case. Different process. Yes?
But if you do the surgery, sometimes it happens that the result is not
the same. Okay.
And what do you do, or what do you say to your patient?
Yes, I have thought a lot about that. I think we have to use it, but not to give to the patient image. Of course. I think there is a weapon to convince or to feel more comfortable with the surgery. But I think we never should give the patient the pictures.
What do you say they ask for? What do you say they ask for?
I don't have it. I don't have it. The system doesn't allow me. The system doesn't allow me to keep it.
Well, a colleague of mine, he's quitting because he does no surgery and has this stuff. And
3D.
Probably it's the best.
There are other different ways to show projection. You can show projection with these different ways, with the black